to be here. My name is Anna. I'm the research coordinator for the CORIG-funded CEDAR study here at the UBC Center for Rural Health Research. I'm calling in from the unceded and traditional territory of the Shishal First Nations today. So thank you for having me be here. I might give Alex a chance to introduce herself as well.
Hello, everybody. It's a pleasure to be here. As Anna said, I'm Alex. I'm the research assistant on the CORIG project, and I'm calling in from the traditional and unceded territories of the Lekwalgan speaking peoples of the Esquimalt and Songhees First Nations. So I'll pass it back to Anna.
Great. Thank you, Alex. And maybe let Stefan introduce himself as well. Thank you, Stefan.
Thank you both, Anna and Alex. That's great. I'm calling in today from the traditional territories of the Coast Salish peoples, and I'm very pleased to be here. This study is really about the capacity of rural communities to look after themselves. That's what we're fundamentally trying to understand. I'd like to acknowledge the Foundation for Advancing Family Medicine and the CMA Foundation for the funding that they have given us to carry out this project. And just to get us rolling, I think I'll flip it back to Anna, if that's okay with you, Anna.
Good. In terms of land acknowledgement, of course, we would like to acknowledge the ancestral, traditional, and unceded territories. We're on the Coast Salish peoples, the Lekwalgan speaking peoples, and of the Shishal Nation. So in terms of our research aims, as Stefan described, we are trying to understand a broad picture of community resiliency, initially engaging with rural physicians as well as community members to understand the strategies that support rural community resilience during ecosystem disruptions, specifically those related to health and to health service delivery. So the way we've approached this is to understand lessons learned from the first year of the COVID-19 pandemic, hoping to translate those lessons and those strategies to future ecosystem disruptions. So for example, future pandemics to climate change as well. So by understanding this, we've really tried to pull out overarching themes and try to understand those community level strategies that can be used in future initiatives. In terms of our project timeline, in June 2021, we received a notification of our successful grant application. Alex and I joined the team at the start of October of 2021, and we have sort of at this point been able to have a broad community sampling strategy across Canada, initiated through our Society of Rural Physicians of Canada conference contacts. From November to January, we had ongoing recruitment of communities and data collection through a series of interviews that we conducted initially with physicians and then through snowball sampling with other community members. That data collection is still ongoing in a certain capacity. We're hoping to leave the door open to certain interviews that we'll collect after community forums. So the first community forum is actually later today. We are sort of returning to these communities with our emerging themes and our overarching interim results to see if we got it right and have an opportunity for community input and reflecting our results back to see if they have additional comments or if it resonates with them. Following these community forum stages, we will be presenting our results at the SRPC conference, which is April 21st to 23rd of this year. And we really do hope to present a survey prior to this as well. This survey will hopefully capture a couple of these initial themes that we've pulled out, specifically looking at physician payment models, for example, and whether this does indeed support community level resilience. In May, we'll be implementing a toolkit supporting community resilience in 5 demonstration communities. And what we hope to do here is translate in an educational capacity our initial results and try to see if we can really help develop resilience and sort of in an almost coaching or facilitation manner, support resilience in other demonstration communities. From June to December of this year, we'll be drafting our results, preparing additional knowledge translation materials and publications. In terms of study methods, we are taking, of course, a qualitative exploratory approach through virtual semi-structured interviews with rural physicians and community members. These were approximately 1 hour in duration each. Our snowball sampling was initiated through those seed contacts from the Society of Rural Physicians of Canada, as well as our study co-investigators. And so we've really spoken with a broad cross-section of community members. We've had the chance to meet with grocers, pastors, really a broad range of community members to try getting as many perspectives as we can, and keeping in mind that these stories should come from not only the physicians, but the community members themselves. These interviews were all audio recorded, transcribed, and Alex and I have been completing a thematic analysis using in vivo 12, again, trying to understand both the stories, the anecdotes, as well as those overarching themes that support resilience. And as I mentioned, we will be returning to these participating communities to share our findings, receiving feedback, and really trying to make sure that we got this right in our story. Maybe I'll allow Stefan to introduce our overarching questions here, as well as our interim metrics of how far we've progressed to this point.
Thanks, Anna. That was very elegantly done. It sort of threw you out in front of the bus there for a moment just to see, or not to see, but just because it seemed like the right thing to do. So thank you. I think that the important thing about presenting a timeline, which we just did, is to be on it. And I think we are on it. It's going quite well. And that's largely thanks to Alex and Anna and the hard work that they've been doing. The emerging themes have been surprising to us a little bit, and I think that we've done 64 interviews now. We've been to 22 communities, and we intended initially to just look at a smaller number of communities, but we found with the snowball sampling, it didn't always take us deeper into a community, but rather to another community. We've analyzed 36 transcripts, and we're proceeding to do them all. We have ended up in 4 Canadian provinces. We're probably a little shy on the north yet, and we probably need to develop our Indigenous understanding and understanding of Indigenous communities a bit, as well as youth perspectives, but we're working on those things. The original question was really what we can learn from the COVID-19 pandemic, because a rural community will respond to the best of its ability to whatever the shock is, and climate change and ecosystem disruption, of which COVID-19 is an example, is only, is just one crisis of many lately. Who knows what will happen with the Russia conflict at the moment? The Ukraine must be a very difficult place to be right now, and who knows what the implications of all that will be for all of us. Let's go to the next slide. Okay, I think I'll flip this back to you, Anna and Alex.
Good. Thank you so much, Stefan. So presented on this slide is really the overarching themes that are emerging thus far. Of course, keeping in mind we have about 37 transcripts analyzed at this point. These are still interim findings, but what have emerged are a couple of, specifically I would speak to the ones that are surrounding relationships. I would say many of these in terms of building trust, communication, those really do, lend themselves to relationship building as an overarching theme that has come from this, both with community organizations, community members, Indigenous communities, and the health system more broadly. So this slide just provides sort of an overarching screenshot, but Alex and I will be describing in more detail at least 4 of these themes that we present here.
Maybe I'll jump back into this one. These are a couple of quotes that I think really touch on what I think is important to think about in rural community, in working with rural communities. These quotes speak to I won't read them, but give you a moment to read them yourselves. So this is really speaks to the heart of the community, the community's ability to pivot and recognize that they have a lot of strength, and that those strengths go deep in the community, and they're part of the history of the community, and that while providers are a part of those strengths, there's often almost invariably a great deal of strength in other parts of the community, and sometimes the providers are even less important than in other communities. So we really found a variation in how communities responded, but these quotes were right on point. Let's go to the next slide.
Thank you, Stefan. So as I mentioned, we'll just discuss 4 of the most important themes that have come up at least to this point in our analysis. The first here being health service delivery. And so here, payment models that support physician autonomy really emerged as important in supporting resilience. Many physicians endorsed APP, that's an alternative payment plan, as opposed to, for example, fee-for-service models. So APP models that provide a salary or a blended capitation approach can support physician autonomy in terms of work-life balance, as well as in terms of relationship building with patients in ways that fee-for-service models might be less supportive of. And in parallel, with payment models, continuity of care was very important to resilience, and APP models often do support those longitudinal relationships. And many providers said that that was really essential to the way that they provided care and were resilient during the pandemic. Participants also highlighted providing culturally competent care and building relationships grounded in trust, in respect, and in cultural humility with Indigenous community stakeholders. So the strength of a really team-based primary care with an emphasis on quality improvement and a resilience really being grounded in relationships, as I mentioned, both between care providers, with patients, and with the health system more broadly. So I would say the social determinants of health are really central here, and our challenges in health service delivery very often do stem from these upstream equity concerns. So one Ontario-based physician here captured this very well when they said, I'll sum it up in 3 words: equity, justice, and fairness. We don't have healthcare problems, we have justice, fairness, and equity problems that we're seeing through a lens of healthcare.
Thanks so much, Anna. I'll jump in to go over our next theme here. And really through our research, we found countless examples of rural Canadian communities taking initiative to overcome barriers, strengthen relationships, and develop better quality care for their rural patients. And I'll point to a quote here on the left that really encompasses this innovation about wanting to emerge from COVID better than how we went into it. A new normal with a new value system, again, that's going to emphasize value equity, justice, and fairness. So a couple of the innovations that we've pulled out from our research are on the right here. The first being a cultural safety and humility retreat, which was enacted by a rural community in BC in order to develop a practice for their physicians that appreciates the culture and the Indigenous community that they reside in, and in order to structure their primary care model in a way that appreciates these different approaches to care and values equity and access to resources in a culturally safe way. And another key component of this is that the youth of the community participated in producing video resources for the cultural safety and humility retreat that allowed them to share their voices in this engagement as well. A second example came from a rural community in Ontario, where they formed what they called a community collaborative table, which was enacted at the beginning of COVID with initially health team members, but they quickly realized that a strategy that just included physicians was not going to be representative of the entire community. Therefore, they invited key municipal leaders, school board members, religious leaders, and their Indigenous partners to ensure a collaborative approach to their COVID preparedness and public health directives. And this was really built on a strong foundation of powerful relationships that have existed in the community, and just gave the community an opportunity to share strategies to overcome communal barriers. Another important innovation that we pulled out from several communities was the idea of a not-for-profit community and social service system. So one community built on their culture of volunteerism to establish several not-for-profit community services, such as a ski hill, a golf course, a curling rink, in order to provide reduced rates for their community members and to encourage a space for relationship building and community connection. This system was also translated into developing a primary care network that allowed the doctors to prioritize providing care, where the primary care network was in the role of establishing the clinic and running the day-to-day practices, which allowed for a good system to improve relationships within the community. And another really important initiative that has been pulled from our research is a food recovery depot, where this innovative strategy supports many families and individuals in the community to improve their food security, as well as reducing food waste that has been created from local grocery stores. So just a few really important innovations that have come from our rural research.
Good. Thanks so much to speaking to those, Alex. So communication, and especially methods of communication, were very important for us to explore in this study, both in terms of disseminating public health directives, but also in terms of those which were the most useful and have the highest uptake among community members. So one that certainly stood out was social media, and especially using Facebook. So a physician stated that they were trying to find a medium with which our patients were actually communicating in real time. So they were not listening to the radio or reading the paper, but everybody and their cousin was on Facebook. So that being said, we did also see success in communities that have a local newspaper, for example, so where there are local advertisements and one community member that consolidates the relevant health information and initiatives taking place in town. So just to say that a bit of mixed findings on that, it wasn't only that social media and Facebook were relied on, but that there were other strategies that certainly were supportive in community use and community communication. Certain primary care provider teams allocated resources to create a health promotion position. So they supported health messaging throughout the pandemic and were really essential in supporting additional communication strategies with community members, both in terms of general health promotion and in terms of public health directives. So many folks also endorsed in-person connection as being among the most important ways to communicate for them. This was definitely a challenge, for many of us during the pandemic. And in these rural communities, you saw people looking for other ways to connect. So for example, they would talk outside the grocery store, or they would talk to each other at the local post office. And it was sort of touching to see how those became sort of informal social hubs to many community members. And when it came to public health messaging, and especially as public health directives were frequently changing in many settings and sort of diverse in how they were implemented in different Canadian provinces, what really was important to community members was at least that those messages remained cohesive, concise, and accessible to as many people as possible.
Another major theme that's emerged throughout our research is leadership. And due to the nature of our research and our grant, the initial contact into these rural communities was primarily through the lead physician. And part of what we were interested in understanding is the role that the physician plays in leadership, not only during COVID, but throughout their community and in all different areas. Throughout our research, we found that the roles varied greatly between communities. And there's two quotes here that both from municipal leaders that point to the discrepancy in these areas. The first participant highlighted their disappointment that physicians did not seem too active or present as leaders during the COVID-19 pandemic. They state, "So I don't really see the physicians step up." The participant pointed to the fact that they couldn't think of one instance in which a physician was really active in conversations surrounding COVID, at least at a municipal level. But in comparison, the second quote points to the level of trust that the physician in their community has been able to establish, that this physician is a lead, they're looked to, as is their partner, who is also a physician, and they've built a lot of trust in their community, which has allowed them to be successful leaders. So a few of the variable factors that we have found that pointed to the success of physician leadership was the importance of continuity of care, the time to build relationships with patients, be involved in community activities and cultural events, increase their presence in the community in order for the community members to look to them as leaders and appreciate that their physician is there for them in more than one way. This builds trust, as is highlighted here. And as Anna mentioned previously, the role of the payment model to support relationship building, allowing a physician to have more time in an APP model, largely to not just focus on billing and getting through patients quickly, but establishing longer term relationships through continuity of care and having the ability to be paid for out of clinic time as well. But it wasn't just physician leadership that we saw emerging through COVID. There was some unconventional leadership areas as well. Many pointed to a specific radio host, grocery store owners that really stepped up during the pandemic to build trust in their community and to show a united front that we were all in this together, and the appreciation that leadership comes from many different arenas.
Good, thank you so much, Alex. I might pass it here to Stefan as we are on the final 2 slides, just to introduce the 5 workshops that we've put forward for the Society of Rural Physicians of Canada conference, which I mentioned will be later in April this year.
Thanks, Anna. But before I plunge into the SRPC conference workshops, I just want to reflect for a moment on the study and the opportunity, the remarkable opportunity that the study has given us to try and understand the life force of a rural community, almost the physiology of the community. How does a community work? You know, we went into the study with lots of biases, lots of presuppositions about what we were going to find, and sometimes we didn't find those things. Like we didn't find, for example, that physicians were all that important in some communities. And it seemed like while continuity of care is fundamentally important, continuity of relationships is important everywhere, whether it's, you know, with the municipal council or with the physicians. The payment model seems to actually make a difference. Like if you're running a business, not surprisingly, your focus is on the business. If you're working in a job where you're paid a salary, you have a broader scope of activity. So we found some interesting things that we hadn't really expected, and we're still finding them. The SRPC conference is really our moment of trying to, we see physicians as being a potential influencer for rural communities. They're educated together, they go into the community with a lot of idealism and most of the time, and they have the opportunity to shift a community, to influence a community. So we're going to try and influence physicians to influence communities by presenting some of the work that we've done. And so we're going to start with a workshop that summarizes in various ways what we've accomplished so far. We're going to have some medical students who are part of our team talk about climate change and ecosystem disruption and the relative absence of curriculum for them. We're going to talk to we're going to have an opportunity for Indigenous community members to talk a little bit about what they've learned through this project. We're going to have a youth-oriented workshop, and then finally, we're going to work with communities, set up the situation with communities that we hope will occur after the conference, where we'll actually have some communities that will want us to consult with them, to work with them to enhance their resiliency. So that's sort of a quick snapshot of what we'll do at the conference. And finally, we're going to pull together a symposium at the end of May for 2 half days. And we're going to invite many of the community members who have participated in the project to come to this symposium, as well as a broad range of other folk, where we're going to really summarize on the first morning what we've learned through the project and what we've learned about community resiliency, and in the second morning we're going to look at where we go from here. And we envision a longitudinal relationship with longitudinal partnerships with communities, with other rural doctors, with leaders, to look at how we can go forward into the future and enhance the resiliency of rural communities, which is what we're all about. So I'm not sure if we have any more, Anna, but thank you very much for listening. And I think we've left a few minutes for connection, or maybe not, maybe a minute or two. Thank you.
Thank you, Anna, Stefan, and Alex, so much for that presentation, and exciting to see there's so much still to come. We do have time for questions if anyone has any questions for the 3 presenters today, and I'll open the floor to that as well. So you're welcome to unmute and or share your camera if that feels comfortable, or you can always enter into the chat also. I'm trying to get at providing a pause without me just speaking. I feel like I've just been usurping questions by asking questions. I do have like a broad question then to ask the group, and we can go individually if you'd like, which is how has this research shaped your work moving forward? And I guess I'll start alphabetically. I'll go to Anna first.
Good, thank you, Kim. It's a big picture question. I think what I've really taken from this work so far is, as Stefan mentioned, sort of the unexpected elements or things that we hadn't been considering before. I think many of the themes that we've seen emerge individually are fitting together in ways that we didn't understand at the outset. So as I mentioned, seeing relationships as the overarching theme, that sort of has only solidified or become clear in the past couple of weeks. We initially thought, communication, building trust, that these were sort of important components, but it's really become clear, and I think reflected in many of the other presentations earlier today, that relationships are so at the core of rural communities, and certainly in terms of supporting resilience. So I look forward to working on strategies that can support those relationships, that can support building trust. And I do hope that in our educational toolkit and in some of those knowledge translation activities that we can translate this research to support that.
Maybe I'll add a little bit to that, Kim. There've been a couple of really aha moments in this work that have been really eye-opening, and another one, aside from the physician payment model's influence, has been around not-for-profits. And the idea that a community could build upon the resources that are often around the community, maybe the forests or the mines, and take some of that revenue and enhance the community, enhance the community's youth, enhance the community's programs. And so we had some really interesting examples we've come across in specific communities. And we've also come to the edges of that. So where we found a community that had done some really interesting not-for-profit food recovery and food distribution programs, really to the point of even hiring chefs to create meals and freeze them with using food that had been recovered from the local grocery store that was about to go in landfill. Really innovative thinking. And then when we explore that a little further and look at other communities, we find that we come up against the for-profit edge, where people are saying, well, the only way that we can actually engage farmers in contributing excess food is if they see it as in a for-profit light, or we see it in a for-profit light. So, and for-profit is a little bit different, because now you got to make money, and now you can't really try and just give food to the community because you've got to sell it. That's how it works. So it's a really interesting edge to the work. And the one last comment I would make is that we came across so much passion, people who love their community, who are passionate about their community, and were willing to work hard to enhance their community. And that was always a good thing. Like, there was so much energy in that was directed into the community.
Thanks, Stefan. And I do recognize we might get booted out of the room in a minute. So Alex, the last words are yours.
Thanks so much, Kim. Yeah, I echo both the sentiments of Stefan and Anna. Coming from a background of not doing any rural health research and not having lived in a rural community, I've just been struck by the power of relationships, the power of innovation, and understanding the importance that while each community struggles with their own independent challenges, a lot of the challenges are unique to rural communities, and that collaboration between rural communities can really overcome a lot of these barriers. So I appreciate the opportunity to share our findings and this great avenue to explore other research in this field. So thanks again, and looking forward to the rest of the day today.
Thanks, Alex. And I can say, if we have a little clock, it feels like a countdown. Anyways, I'm envisioning like a mission launch countdown. I don't know if it's because I was watching a show and saw that on there recently, but so with 1:27 to spare, I just wanted to thank Anna, Stefan, and Alex again for the presentation, and I look forward to hearing more as it moves forward. If anybody would like to connect with Anna, Stefan, or Alex, their bios should be available on the Feedloop platform, and if you have any issues connecting with them, feel free to message my team at research@interiorhealth.ca, and I'd be happy to facilitate that connection onwards. I'd like to thank everybody for joining this room today for when you could. I know we've had people pop in and out, and that's totally fine. We thank you for your time. And we'll be getting shifted back into the main room here in 51 seconds, where we'll have a closing discussion and some amazing, I'm sure, last words from Elders Pamela and Wilfred Barnes, who are in my Brady Bunch square to the left, and as well Katrina Plamondon and Dee Taylor. So thank you guys all for joining, and I'm sure we'll get shifted in, well, now 33 seconds. And thanks again. And thanks to Jordy. I want to make note of Jordy with the Rural Health Services Research Network at BC, who's providing the tech support in the background and making this all look seamless today. So big props to Jordy. Thanks so much.